There is no extra question, so we can move to the next presentation, to the next very interesting presentation from Professor Abbate. And the topic of his presentation is IL-1 inflammasome pathway in cardiovascular disease. Professor Abbate.
Hello, I'm Antonio Abbate. I'm a professor of cardiology at the University of Virginia in Charlottesville, Virginia, United States. It's really an honor for me to be here and present to you about a topic that is very dear to me, about interleukin-1 and the inflammasome as therapeutic targets in cardiovascular disease. I'm going to be covering the mechanism of involvement of the inflammasome and interleukin-1 in cardiovascular disease, particularly how inflammasome and interleukin-1 can be therapeutic target in acute coronary syndromes, heart failure, and pericarditis, which is a clear autoinflammatory disease. The interest in inflammation in atherothrombosis dates several decades. This is a seminal review article from Russell Russ, from the late Russell Russ in New England Journal of Medicine, 1999, that summarizes how atherosclerosis, that was thought to be a metabolic disease, was clearly a chronic inflammatory condition. In 1994, this article came out from the group in Rome, the Catholic University of Rome, led by Attilio Masadi, and Giovanna Liuzzo, and Filippo Crea, Luigi Biasucci. This is the group I trained with in Rome, and showed that a simple inflammatory biomarker, C-reactive protein, could predict outcome in patients with acute coronary syndromes independent of the presence of myocardial necrosis. That was a landmark article, stimulated a lot of research down the road. If you talk about inflammation and atherothrombosis, you need to know Peter Libby. He writes wonderful reviews, and he's done a lot of research in the field, and it shows how the molecular and cellular mechanism of inflammation and atherothrombosis. And you need to know Paul Ridker, who is the clinical trialist that has done most research on inflammatory biomarkers as prognostic markers in patients with acute coronary syndromes and other forms of cardiovascular disease, and has also led clinical trials with several lipid-lowering and anti-inflammatory therapies. Paul Ridker is a great speaker and a great writer, and so I borrow from him this review article from European Heart Journal 2021, where it summarizes how inflammation evolves in patients' response to injury. And he depicts here two patients, patient represented 2 on the right, patient represented 1 on the left. I would have probably flipped them and presented different 1 and 2, but the concept should be very clear. The patient on the right has a low level of inflammation at baseline with the C-reactive protein less than 2, has a mild response to injury, which is normal, that's what we would like to see, and it recovers rapidly with inflammation resolution. The patient on the left, on the other hand, the inflammation is already elevated before the start of the acute coronary syndrome, in which case inflammation can be the cause or trigger of the acute coronary syndrome. There is an intense inflammatory response that predicts adverse outcomes, including heart failure and recurrent MI. And there's lack of resolution of the inflammation. And this is the concept of inflammation as residual risk, which can predict and cause long-term consequences of the acute coronary syndrome. Along these lines, this is again another review from Paul Ridker. We can see a schematic where C-reactive protein is an inflammatory biomarker downstream produced by the liver in response to interleukin-6, interleukin-1, and the production is within the inflammasome, a macromolecular structure in response to several injury. We'll see more slides soon. This injury or stimuli can be molecular, can be infectious, can be also physical triggers. And Dr. Ridker has shown in many of his studies that C-reactive protein is associated with a dose-related risk of having adverse coronary events, and the predictive role is as important as other classic risk factors, if not even better. Talking about interleukin-1 and the inflammasome, we need to mention Charles Dinarello, who is the discoverer of interleukin-1. He's also responsible for cloning the gene for interleukin-1 beta and has written most about this, and I encourage you to read some of his articles. And know that Peter Libby and Charles Zinarello actually worked together many years, decades ago, and together they identified interleukin-1 as an important factor in endothelial pathology, that it's the basis of atherothrombosis. In this review that Stefano Toldo and I wrote in Nature Review Cardiology 2024, we review how the inflammasome and interleukin-1 are central to a long list of events that characterize atherothrombosis, including the formation and growth of the atherosclerotic plaque here on the left, the thrombotic event and the ensuing ischemia, the acute ischemic injury, the reperfusion injury and the remodeling, and the progression to heart failure. On the right is one of the many schematics of the inflammasome, which is this macromolecular structure sensing and amplifying the response to injury. And I will go to this slide here where we can simplify the process in 3 steps. A priming process where the danger-associated molecular patterns or the pathogen-associated molecular pattern induce the production of the components of the inflammasome need to be expressed in the cell. The inflammasome now is formed by a macromolecular star-like structure that comes together when there is a trigger. This trigger can be extracellular damps or can be injury affecting the potassium influx, like destabilization of the lysosomal context from crystals. And that leads to the active inflammasome structure and autocleavage of caspase-1, which is the effector enzyme, and the production of pro-inflammatory cytokines like interleukin-1 beta, interleukin-18 that are released outside the cell through Gus-Dermin pores and now have an effect locally and systemically. Interleukin-1 beta is also known as the fever molecule. Down on the right, we can see that activation of the caspase-1 and the creation of Gus-Dermin pores can induce to inflammatory cell death or pyroptosis. So along these lines, we have learned now decades ago that the inflammasome is that link between the cholesterol crystals and the pro-inflammatory complication in the plaques. And there's been several preclinical studies that I'm going to summarize here very briefly that link interleukin-1 and the inflammasome with experimental atherosclerosis in the mouse. Mice that were deficient in interleukin-1 beta indeed had limited aortic atheroma when they were fed high-fat diet. If there was a deficiency of the components of the inflammasome, like an LRP3 or ASC, or the effector, interleukin-1 alpha or beta, there were limited aortic plaque in this study coming out into 2010. Similar, a blocking of the interleukin-1 beta with a drug-like antibody reduced aortic atheroma in this 2011 paper. Disruption of IL-1 receptor reduced aortic atheroma and outward remodeling in the ventrocephalic branch, and disruption of IL-1 receptor reduces fibrous cap formation and outward remodeling in this Nature Medicine 2018 paper. So over more than a decade, preclinical data accumulated linking the interleukin-1 beta and the NLRP3 inflammasome to atherosclerosis and atherothrombosis in animal models. That is the basis for the CANTOS trial. Top right, you see Peter Libby, Paul Ridker. They're were the PIs of the study, and they're definitely the big expert in this field. And they designed a double-blind, placebo-controlled, randomized trial with 3 active treatment arms for canakinumab, 50, 150, and 300, in an event-driven study. The study was initially planned to have 7,300 patients, then expanded to 1,700 patients, and then actually reduced to 10,000 patients with a longer follow-up, with a final of 10,061 patients. What did the trial show? That was the first trial to show that you can have a dose-dependent effect on inflammatory biomarkers like C-reactive protein, independent on effects on lipids or blood pressure. So it's really the first trial that shows a targeted anti-inflammatory therapy blocking interleukin-1 beta that had a very effective reduction of systemic inflammation and could read now into clinical outcomes. Here are the clinical outcomes here. Of the four right panel, I selected the pre-specified dose. Preferred dose was 150 milligrams versus placebo, and that was associated with a hazard ratio of 0.85 for major adverse cardiac event compared to placebo. So the trial met the primary endpoint, and was the first study to show that anti-inflammatory therapy could reduce atherosclerosis and complication. Following that, or concomitantly with that, there has been attention to another anti-inflammatory drug, colchicine. Colchicine is actually an ancient anti-inflammatory drug that is shown to have multiple effects, including a non-specific effect on the inflammasome by preventing the aggregation of the ASC polymers in the inflammasome, but also affecting the lysosome stabilization and formation of pores and release. Colchicine, the schematic here on the right, would be on the top here, where it's looking at the inflammasome inhibitor here, where canakinumab would be on the step below, inhibiting interleukin-1 beta. What did the trials show? These are two major trials that came out in 2019 and 2020. These were phase 3 trial. On the left is the COLCO trial that enrolled 4,700 patients with recent MI randomized to colchicine or placebo. On the right, it was the LODOCO 2 trial, 5,500 patients with stable coronary disease, also randomized to low-dose colchicine or placebo. They both showed a significant reduction in adverse cardiovascular events over a period of a few years, with a hazard ratio that was between 0.77 and 0.69. This has led to the FDA approval of colchicine as the first anti-inflammatory drug for the treatment of cardiovascular disease in 2023. For completeness, I want to show you the Clear Synergy trial as well. These are data from 7,000 patients with acute MI, mostly STEMI, randomized with colchicine or placebo, or spironolactone in a 2x2 factorial design. This trial, contrary to the other trials, showed no benefit of colchicine on top of optimal medical care, which in this case included dual antiplatelet therapy and stenting. How do we reconcile these data? Well, there are several meta-analyses that came out that showed that even when you include the Clear Synergy trial in all the trials, there is a statistically significant reduction in adverse cardiovascular events with colchicine compared to placebo. The benefit is perhaps more pronounced in the stable coronary disease patients and less so in acute MI patients, but overall there's a benefit for this strategy. Moving on to acute myocardial infarction, I'm going to be covering mostly the VCR trials. During acute myocardial infarction, there is necrosis of the tissue that triggers an acute inflammatory response. This is usually due to an acute coronary thrombosis. And the patients with acute myocardial infarction, although they're surviving more, they're at risk for heart failure. And so we know the degree of the inflammatory response during the acute myocardial infarction correlates with the risk of heart failure and adverse cardiovascular events in the follow-up. There are several studies performed in animals showing that the IL-1 beta and NLRP3 inflammasome are involved in the response to injury and healing process after an experimental acute myocardial infarction. This one here, this is actually one of my papers, Circulation 2008, blocking the interleukin-1 receptor with anakinra reduced apoptosis and adverse remodeling in mice and rats. This is again a paper of mine in 2010, blocking interleukin-1 beta with antibody had a favorable effect. This is the same strategy used in the CANTOS trial. This is also from our group in Virginia, inhibiting or interfering with the expression of the NLRP3 inflammasome, reduce infarct size and adverse remodeling. Finally, also our team in Virginia showed that a pharmacological inhibitor of the NLRP3 inflammasome reduced infarct size and improved adverse remodeling and heart failure in a variety of models. In this study, in the final study in 2017 in European Heart Journal, the inflammasome inhibitor was used in large animal model in pig. So based on this basis and others, we have designed and conducted several trials in patients with acute ST segment elevation myocardial infarction. We are presented to study the result of the combined pooled analysis of 3 trials, the VCR, VCR2, VCR3. These were 10, 30, and 99 patients, different sponsored, very nearly identical inclusion-exclusion criteria. What we're really testing here is, could inhibiting inflammation with anakinra lead the patients 1 to look like patient 2 in the schematics of Paul Ridker, so a reduced intensity acute response and a more rapid resolution of the inflammation. Here, the pooled analysis was published a few years ago in European Journal of Cardiovascular Pharmacology. What we find here on the top right is the patient with placebo had a classic rise and fall of inflammatory biomarker C-reactive protein, when that increase was significantly blunted by anakinra, leading to a lower level at day 3 and day 14. And this was associated with numerically lower incidence of heart failure events. On the left, a reduction in death and new onset heart failure. On the right, a reduction of death or heart failure hospitalization. These are small numbers, but still are encouraging, suggest that treating the inflammatory response during the acute myocardial infarction may blunt the systemic response and prevent adverse consequences like heart failure. Talking about heart failure now specifically, the link between interleukin-1 beta and cardiac dysfunction is known now for several decades. In these in vitro experiments by Parillo and others, the plasma from patients with sepsis was shown to have an inhibitory effect on cardiac cardiomyocytes in vitro, the same group showed that this inhibitory effect was actually mediated by soluble interleukin-1 beta and TNF in circulations. Our group showed that you can actually reproduce the cardiac dysfunction in the mouse with exogenous interleukin-1 and also with plasma of patients with decompensated heart failure. And in a pilot clinical trial in patients a few years ago, we showed that blocking interleukin-1 with anakinra improved peak oxygen consumption in a study of patients with heart failure, with systolic heart failure. Along these lines, this led to the design and conduct of the Red Heart trial, where we took patients with recently decompensated heart failure and reduced ejection fraction, and we treated them with either anakinra for 2 weeks, anakinra for 12 weeks, or placebo. We measured peak oxygen consumption, and we looked at heart failure hospitalization. The study was pretty small and only included 60 patients in total. Here on the top right, you can see that in the patients treated with anakinra for 12 weeks, there seemed to be an increase in peak oxygen consumption and an improvement in the VCO2 slope, a reduction. That was not seen in the other groups. And here in the bottom panel, you can see the patients that were treated with anakinra for 12 weeks actually had tended to have fewer rehospitalization for heart failure compared to anakinra and placebo. Again, small numbers. We just completed the Red Heart 2 trial, which it was presented briefly at the European Society of Cardiology, and it's now under review for publication. And we know there's more heart failure trials ongoing. If we go back to the CANTOS trial, we actually can see that in the CANTOS trial, there was a sub-analysis here on the right, looking at how canakinumab could prevent hospitalization for heart failure, and canakinumab was associated with a dose-dependent reduction in heart failure hospitalization in this trial, though that was not the primary endpoint. We ran a sub-study here on the left of patients in the CANTOS with systolic heart failure at baseline. They were treated with canakinumab, and we showed that at 3 months and 12 months, there was a statistically significant improvement in peak VO2 in these patients. So again, linking IL-1 blockade to improved peak VO2 and reduced hospitalization. There are other trials that have been published on this topic here. I'm not going to be able to review it, but these are available in our review article. Finally, I want to take you to the pericarditis. Pericarditis is a model of injury and inflammation and unresolving inflammation in an autoinflammatory loop in the pericardium in which the inflammasome is central, and IL-1 blocking therapies are now central to the treatment of more complex patients. In this paper that we published a few years ago in JACC Basic Translational Science, we showed that the samples of patients who undergone surgery for constrictive recurrent pericarditis showed an intense expression of the component of the inflammasome. We could reproduce that inflammation and thickening of the pericardium layer in the mouse by instilling an inflammasome activator known as zamicin A, and we could see that there was an increased expression of all the components of the inflammasome inhibitor. In this model, we also showed that inhibitor of the inflammasome, like colchicine or a small molecule, or inhibitor of interleukin-1, like anakinra or an IL-1 trap that is similar mechanism to rilonacept, reduced in the animal model pericardial effusion and pericardial thickening. Along these lines, it's easy to interpret the results of the colchicine trial. These trials was done mostly by Massimo Emazio in Italy and his colleagues, and they go back 20 years. In the left one is the COPE trial. Colchicine shown to reduce the recurrence after a first episode of acute pericarditis. In patients that were treated with aspirin or aspirin and colchicine. On the right here, you can see that this in the second trial, there's 240 patients also treated with colchicine, and also a significant reduction in recurrences. On the left here in the COPE trial, these are patients that are not at the first episode but at the first recurrence, and on the right is patients with multiple recurrence. In all these cases, treating with colchicine for 3 to 6 months reduced the recurrence of pericarditis, and that is in line with an anti-inflammatory effect of colchicine. For those patients that don't respond to colchicine or cannot tolerate colchicine, and or cannot tolerate or did not respond to prednisone steroids, there are 3 separate trials done. The left one done mainly in Italy in the Mediterranean. The one in the middle was done in the United States, the Rhapsody. The one on the right was done mostly in Russia. The one in the first one was done with an anakinra, the receptor antagonist. The one in the middle was done with an interleukin-1 trap. The one on the right was done with a different trap called goflicicep. They all show remarkable similar effects, whereas after an initial response to treatment, patients were randomized to withdrawal of the active treatment or continuation of the active treatment. And you can see here that withdrawing the active treatment led to a very high numbers of recurrences, whereas continuing the active treatment, whether it's anakinra, rilonacept, or goflicicep, maintains the patients in remission free. And that has led to rilonacept and anakinra as being recommended for the treatment of recurrent pericarditis after failure of first-line treatment like colchicine and NSAIDs. These are some review that we wrote on this topic, and there's more now consensus statements and guidelines along these lines. So I think we can take this to the conclusion here. I hope I convinced you that interleukin-1 is a central mediator in atherothrombosis, and that in patients with prior MI, chronic inhibition with interleukin-1 beta with canakinumab significantly reduces major cardiovascular events. Of course, the canakinumab is not FDA approved for this indication, but it shows a proof of concept of the centrality of interleukin-1 beta as predicted by the animal models. In patients with acute MI, interleukin-1 seems to mediate the systemic inflammatory response, and in patients with ST segment elevation MI, treatment with anakinra for 14 days appears to blunt acute inflammatory response and appears to reduce the incidence of heart failure. These are data based only on phase 2 trials, so anakinra is not approved for this use, but certainly provides that link that it was also supported by the animal data. And it's important to know now that there are ongoing trials with interleukin-6 inhibitor, ziltivekimab, that are downstream for interleukin-1 beta, looking at chronic atherosclerotic disease, like CANTOS trial, it would be the ZEUS trial, or in the acute myocardial infarction, like the VCUR trials, would be the Artemis trial, both done with ziltivekimab and both aimed at seeing if blocking interleukin-6 downstream from interleukin-1 beta can have the similar beneficial effect. We also shown that interleukin-1 negatively modulates cardiac contractility, and I would add also cardiac diastolic function. We've seen that inhibition of interleukin-1 canakinumab in patients with prior MI resulted in a reduced incidence of heart failure in the CANTOS trial. And then in patients with systolic heart failure, inhibition with interleukin-1 or anakinra was associated with an improved cardiorespiratory fitness. The second part is based on small numbers, but this is, again, providing a link between inflammation, cytokine like interleukin-1 beta, and cardiac function in heart failure. And again, there is an ongoing trial with an IL-6 blockers, ziltivekimab, again, in patients with heart failure and left ventricular ejection fraction of 40% or more. It's the Hermes trial, so these trials will bring more information along this path of the inflammasome, interleukin-1, interleukin-6 pathway. Finally, we know now as a definite that interleukin-1 occupies a key role in the pathophysiology of pericarditis, and particularly in patients with recurrent pericarditis that behaves as an autoinflammatory disease. Inhibition with interleukin-1 with anakinra or rilonacept, and I would add also goflicacept, results in a rapid improvement in symptoms during a flare and significant reduction of recurrences. So put it into summary now, we know that at least in recurrent pericarditis, interleukin-1 is central. Blocking interleukin-1 blocks the entire cascade. We actually don't have any data on downstream mediator like interleukin-6. Those studies may come. There are more trials ongoing with NLRP3 inflammasome inhibitors, oral small molecule, and as we mentioned early, colchicine is also a proof of concept for this, because one of the major function of colchicine is indeed inhibition of the inflammasome formation, activation, release of interleukin-1 beta. With this, I say thank you, and I look forward to coming to Athens for a presentation in person next time. Thank you.
Okay, that was an excellent presentation. Unfortunately, we do not have Dr. Abbate with us, but I can summarize the points of his presentation. I think that we are all convinced that cardiovascular disease and atherosclerosis is an inflammatory process, no doubt about it. Now, Dr. Dan Kastner, almost 20 years before at NIH and NIAMS, coined the term autoinflammatory diseases and the importance of the inflammasome and interleukin-1 beta in the generation and pathogenesis of these diseases. But as you saw and listened, we moved forward, and we've seen that and we were convinced by Dr. Abbate that inflammasome and upregulated interleukin-1 beta is important in cardiovascular diseases, in acute myocardial infarction, in sepsis and cardiac dysfunction, in recent decompensated heart failure, and also, and finally, in recurrent pericarditis. And the good thing is, the important thing is that we have medications such as colchicine and specific antibodies against IL-1 beta that can help us in preventing and treating such cardiovascular maladies. So interleukin-1 beta is an important cytokine in the pathogenesis of these cardiovascular conditions, and is very important that now we have medicines such as colchicines and IL-1 beta antibodies that can help manage and treat our patients. Thank you for your attendance, and now we can move on to the next session.